It's likely you know someone who has an eating disorder. Listen to find out about how medications are used for it.
Hello, pharmacists and friends. Today is Monday, March 18th, 2024. Welcome to the Regimen, where public health pharmacists, pharmacy students, and our guests discuss the latest public health issues. Listen in to find out how we can all improve population health, health equity, and patient care through advocacy and education. My name is Tony Sulo. I'm a 6th and final year Doctor of Pharmacy student at the University of Rhode Island, working alongside Dr. Bratberg and the Rhode Island Department of Health.
And I'm Jeff Bratberg. I'm a clinical professor of pharmacy practice and clinical research at the URI College of Pharmacy and the Academic Collaborations Officer at the Rhode Island Department of Health. As a reminder to our listeners, the opinions expressed in this podcast do not represent the opinions of the United States government, the Rhode Island Department of Health, nor the University of Rhode Island.
As a disclaimer and trigger warning to our listeners, we felt it necessary to divulge our intentions with this episode, as we are aware that this can be a sensitive topic. In support of trauma-informed communications, please be aware that this message contains topics that may be activating for some listeners. 3 weeks ago, February 26th through March 3rd, was Eating Disorders Awareness Week, sponsored by NEDA, the National Eating Disorders Association. The NEDA states, in order to better recognize, support, and effectively treat eating disorders, public awareness is key. This year, we're asking you to get in the know and learn about eating disorders, get involved in raising awareness, and share information and resources. In answering this call to action, we at the Regimen thought, what better way to share information and spread awareness to our pharmacy-focused listeners than to discuss medication management of eating disorders. This episode is strictly for informational purposes, where we will discuss current medical treatment and management of eating disorders, which I'll refer to as EDs for the rest of our talk.
Importantly, we're not experts in this topic, and this is not clinical advice, and we're only broadly discussing this as an overview, not a full spectrum of eating disorders. Importantly, we'll give you this at the end, but also we'll share it now. If you or someone you know is struggling or in crisis, help is available. Call or text the national 988 line or chat 988lifeline.org. So that's call or text 988 or chat 988lifeline.org.
So with that, thanks for tuning in, and Dr. Bratberg, let's get started. There's 3 major types of EDs that we'll be briefly discussing today. They're anorexia nervosa, bulimia nervosa, and binge eating disorder, or BED. There are many other types of EDs, such as avoidant restrictive food intake disorder, or ARFID, other specified disorders, and other unspecified disorders. So for the purposes of our discussion, we'll stick to the first 3 I mentioned, as they're the most prevalent.
Yeah, thanks, Tony. As I've been learning more and more about EDs, because this is unfortunately something that I haven't really known about, I've learned that they're more prevalent than people think.
Yeah, eating disorders affect everyone, so people of all ages, genders, races, ethnicities. Most commonly, we see them more in women than in men. It's estimated that 1 in 5 women and 1 in 7 men will have an ED in their lifetime. We also see these occur more in younger people. 95% of first-time cases of EDs occur by the age of 25.
Yeah, so it's important for especially our listeners and folks who find us on social media who may be under the age of 25. This is really hitting your age group. Importantly, over the globe, eating disorder prevalence has more than doubled between 2000 and 2018, and that's important because that was all pre-pandemic. It's thought that 9% of the U.S. population, or nearly 29 million Americans, will have an eating disorder in their lifetime, and that's based on data from a 2020 research publication on nationaleatingdisorders.org. Eating disorders, and this was really stunning to me, have the second highest mortality rate of any psychiatric illness, right behind opioid addiction. There's disparities in eating disorders, just like in opioid addiction. People of color with eating disorders are half as likely to be diagnosed or to receive treatment. And youth of color, so again, this is really a disease first diagnosed in youth. So youth of color are less than 2/3 as likely to receive recommended treatment compared with white youth. So I think one of the goals of the podcast is to eliminate those disparities. But I think what's particularly focused on ED itself is that less than 6% of people with an eating disorder are medically underweight. So it's really important what Tony said about affecting sort of folks that we don't actually have a picture in our mind of when we think of ED.
I think you bring up a great point there in that most people with an ED actually are not considered underweight. So it's important to recognize that people of all weights can be affected by EDs. When we talk about certain disorders such as anorexia, a lot of people have an image in their head of what someone who's affected may look like. Same kind of idea for binge eating disorder. I just want to point out that these images that you may have are not the only people with these diseases. Every person has a different body, and a healthy body looks different on every person. So as we continue talking about these things, it's important to be aware that not everyone with an ED will look the way you may expect them to, and that people you may not expect to have an ED could. There's a lot of different things that can influence the development of an ED. Dr. Brappert, can you talk a little bit more to those factors?
Well, so here is where what people think influences development of EDs is probably true. Unrealistic ideals or so-called ideals from the media, especially social media, the fashion industry. And this is, I think we've talked when preparing this episode, exacerbated by these miraculous new weight loss drugs that we've had podcasts on, used allegedly or outwardly by famous people and not so famous people. There are mental health events and disorders that people can be diagnosed with related to this, anxiety, depression, adverse life events, and they can trigger them. Of course, speaking of an adverse life event we all went through was the pandemic, and that played a huge role, along with just the ever-infringing modes of social media in our life. I think it's important, though, we can't see that as negative. Social media can also bring awareness. Often it's awareness of the negative stereotypes of eating disorders, but it also means that we destigmatize a lot of mental health treatment and increased access through telehealth, often with less stigma. So the pillar of treatment, and this is sort of what we talk about medical management as an adjunct, the pillar of treatment is really supportive care and treatment of those psychiatric and physical comorbidities, not really pharmacotherapy. There are some treatments we'll talk about that are FDA approved, though, for some of the consequences and comorbidities of EDs.
Yeah, so in talking about more specifics regarding those treatments, there's different avenues of management that we'll discuss. First being the inpatient or hospital management of EDs. We'd like to take this time to acknowledge Dr. Kelly Matson, a clinical professor of pharmacy practice at URI, for her generous assistance with this information. In terms of the inpatient management, this is where, from a pharmacy's perspective, there's more direct pharmacotherapy that can be implemented, and this is mainly through supportive care efforts. Hospitalizations of EDs often occur due to the secondary health consequences of the disorder. So some examples are cardiovascular complications, which are mainly rate-related, being bradycardia or arrhythmias. Some GI complications can include constipation, nausea, or damage to the esophagus, specifically in the case of bulimia. There can also be some endocrine changes like amenorrhea and other hormonal changes as a consequence. So an important aspect of inpatient management is really supportive care of any of these complications that can occur. If the patient is diagnosed as malnourished, multivitamins are typically recommended. Some other vitamins could be calcium and vitamin D, specifically if the patient has osteopenia or bone loss. For constipation, we can use bulk-forming laxatives or stool softeners. And if the patient suffers from bloating or pain prior to meals, we can use metoclopramide. And kind of lastly, for patients who have more severe anxiety around mealtime, hydroxyzine can be given typically right before to help manage that. So really, the main treatment is nutritional rehabilitation, specifically in anorexia. There's weight goals that are achieved mainly through refeeding, which is a process of reintroducing foods after periods of malnourishment. And as already mentioned, really a major component and the most important component of treating any ED is the psychological management that coincides. Dr. Brappert, when would psychiatric pharmacotherapy be used in patients with an eating disorder?
So we look at mainly one class that has been studied the most, and these are SSRIs, examples being Prozac, which is fluoxetine, or Zoloft, which is sertraline, and that's where we have the most data for treatment of different eating disorders. So fluoxetine actually has a labeled indication for adjunct therapy of bulimia, and it's effective in reducing binging or purging, of course, anxiety, depression, and obsession and impulsivity. So a lot of the comorbid conditions of bulimia there. There's another class of drugs that are stimulant classes, and one of them is Vyvanse or lisdexamfetamine. It's FDA approved for binge eating disorders, and this you might know this stimulant class is being typically used for treatment of ADHD. Now, I know that there's some contraindicated drugs. Tony, you want to tell us about those?
So from researching kind of on my own prior to this topic, there's actually a lot more contraindications than I would have expected. And I learned a lot of this from listening to URI grad Caroline Granado. She presented at the Seminar by the Sea this last week in Newport, Rhode Island. And she gave a fabulous talk regarding everything pretty much that we're talking about today. But she brought up some great examples of contraindications in these patients. So tricyclic antidepressants, or TCAs, should be avoided in patients with anorexia because there's an increased potential for some cardiovascular complications that already exist with these medications, those being QT prolongation, arrhythmias, and tachycardia. And these really come from some electrolyte disturbances as well as just the other cardiovascular complications mentioned prior related with these conditions. Another example is bupropion. It's actually contraindicated in patients with anorexia and bulimia. We know that bupropion in general can lower any patient's seizure threshold, and this is especially concerning for patients with anorexia and bulimia because electrolyte imbalances and dehydration are common complications. So just kind of overall increasing that seizure risk. Ethinyl estradiol or other forms of hormonal contraceptive are actually not recommended for patients that I mentioned earlier who may have amenorrhea. This is because a return of menses is a sign of clinical improvement. So for those reasons, they typically don't recommend using hormonal contraceptive to help the return of menses. And I think it's important to talk about these precautions and medications to avoid, because one, we need to recognize that not every commonly used psych medication can be used in patients with an ED, but also because, too, as pharmacists, we should recognize when an inappropriate recommendation is made, and we should intervene to ensure patient safety. So we talked a lot about the inpatient side so far. Dr. Bratberg, what about the outpatient management of ED?
Well, I think building on what you said about contraindications and thinking about, we talked earlier about the increasing prevalence and sort of triggers of things. As pharmacists, if we're managing patients, no matter what area we're in, we should look for some of these medications that patients are on and caution to their use if an eating disorder gets diagnosed and refer and we're made aware of that. I think it's important that for ED treatment itself, it's non-pharmacologic treatment. Everything we've talked about is really about managing comorbid conditions, those electrolyte imbalances, the risks of concurrent medications, medications that we shouldn't start, and then medications that are proven effective and safe for comorbid mental health disorders. A couple things that really work well that were recommended to us and in the research we did, family-based therapy, again, especially since this is such a disease of youth and especially, folks who are living with their family if they're under 18, cognitive behavioral therapy, and there's lots of other supportive care specific to certain EDs like bulimia. There's a focus on dental hygiene, for example. So what are some other things we as pharmacists should be thinking about when treating a patient with an eating disorder?
Something else to keep in mind is the pharmacokinetic or PK changes that can occur in a person's body who has an eating disorder. And these PK changes can affect any medication we recommend, not just medications for treating an ED. So it is important to keep in mind and kind of get a holistic approach to who the patient is and what else they could be going through when we're recommending any sort of medication to them. So in general, patients with eating disorders can have reduced absorption of medications or an increased risk of adverse reactions, and this could be due to their nutritional deficiencies, the differences in body composition compared to those without an eating disorder, possibly not following administration techniques for certain medications, such as medications that need to be taken with a high-fat meal or food in general, and dehydration. So there's a lot of things we need to consider when treating patients. Close observation and follow-up are really key to providing individualized, patient-centered holistic care. For the listeners out there, I hope you learned something today from our discussion and you're aware of some of these things that as pharmacists we should keep in mind when managing a patient with an eating disorder.
All right, thanks, Tony. This is a very informative talk, and again, just the beginning of what you should know. So we encourage anyone to who has interest in more of this as either a professional or for folks in your life. So there's an Eating Disorders Helpline that's put on by the National Association for Anorexia Nervosa and Associated Disorders, or ANAD, A-N-A-D. So for support, referrals, and other questions, they're available at 1-888-375-7767. I'm sure we'll put a link to that on our socials too. So that's the ANAD. For support support, referrals, and general questions for an eating disorders helpline. That's 1-888-375-7767. So I think anyone who's interested can call that. But if you are in crisis or someone you know is struggling, again, it's the standard mental health and substance use disorder helpline. Again, we talked about the importance of this as a psychiatric illness. So you can call 988 or text or chat 988lifeline.org. And again, that's for any kind of problem there. If you want to find out where there's support more generally, you can go to FindSupport.gov. And to find treatment facilities or providers, you can use that FindTreatment.gov number or call SAMHSA's National Helpline, which is 800-662-4357 or 800-662-HELP. So thanks so much for listening, and we hope you've learned something today. Follow us at PharmD.Pub That's Pharm as in pharmacist, at PHARMD as in Dr. Pub Health. We're on all the social networks. Smash that subscribe button there. And also wherever you get podcasts. We're on Apple Podcasts, Amazon Music, and hosted by Spotify. Thank you so much for listening.